Hello students, welcome to my channel eduhub.2m. Today's topic is one very important topic of excretory system, that is the kidney-parathyroid axis. The master regulator PTH. What is the full form of PTH? Parathyroid hormone. It is known as the master regulator. First of all, we have to understand what is the primary role of the parathyroid hormone. Parathyroid hormone or PTH maintains serum calcium with a narrow physiological window essential for nerve conduction, muscle contraction, and the bone integrity. So what is the main thing that the parathyroid hormone do? It actually maintains the serum calcium level. We all know that the calcium ion is very much important for three basic functions of our body. Number one is nerve conduction. Without the presence of the calcium ion, nerve cannot conduct. Number two, muscle contraction. One of the main important thing for the muscle contraction is the calcium level. Next, bone integrity. From the very beginning of our study, we all know that the calcium ion is the main thing that is present in the bone. So these three will hamper if there is not enough amount of serum calcium in our body. Now, what is the second thing? The trigger. When serum calcium drops, calcium sensing receptors on the parathyroid gland. So we have to remember that there are some calcium sensing receptors which are present on the parathyroid gland that detect the hypocalcemia. Hypocalcemia means hypo means less, calcemia means calcium ion, and immediately stimulate the PTH secretion into the bloodstream so that this PTH can absorb more calcium ion and it can maintain the calcium level in our body. So in this case, we have to remember this calcium sensing receptors without which calcium ion cannot be retained within our body. This is a very important structure present on the parathyroid gland. So the kidney as a key target. Last, this line is very important. PTH act directly on the distal convoluted tubule. If we think about the structure of the nephron, just at the end of the Bowman's capsule, there comes the distal proximal convoluted tubule, then comes the loops of Henle, then comes the distal convoluted tubule, which ends in the collecting duct. So this PTH directly acts on the distal convoluted tubule, upregulating the calcium channel to reclaim the filtered calcium before it is lost in the urine. An immediate life preserving response means if the calcium is lost from the body in the urine, then the nerve conduction, the muscle contraction, and the bone integrity, both all these functions will be lost in our body. So the main target of the kidney is to help the PTH to bind with the DCT receptor. DCT means distal convoluted tubule. Then this distal convoluted tubule helps in the calcium reabsorption. So the serum calcium level increases, which prevent the urinary calcium loss. So this is the function of the kidney to retain the calcium ion inside the body. This is the phosphate paradox. How it actually works. Why phosphate must go? When the calcium comes in, phosphate must go outside. PTH simultaneously inhibits the sodium phosphate co-transporter in the proximal tubule, flushing the phosphate into the urine. It excretes the phosphate into the urine in the proximal tubule area. Elevated phosphate could bind the calcium. So this is the reason why the phosphate should go out, because if there is excess amount of phosphate or increased amount of phosphate present in the blood, it will bind with the calcium, which will no more help the calcium to retain in the body, and the calcium will be lost in the urine. So the PTH creates the chemical space for the calcium to rise safely. We can see here that PTH action on the proximal tubule, and it promotes the phosphate excretion in the urine, which prevents the hyperphosphatemia. Hyperphosphatemia means increased amount of phosphate level in the blood, which allows the calcium level to increase and avoid the soft tissue calcification. So the activating vitamin D pathway. PTH stimulates, it activates renal 1 alpha hydroxylase enzyme in proximal tubule cells. So we should remember this enzyme name 1 alpha hydroxylase, which is present in the proximal tubular cells. Then it helps in the conversion of what? Inactive vitamin D into active calcitriol, which is 125 dihydroxyvitamin D. So what is the active form of vitamin D? We should remember that is called active calcitriol. Now there is a chain reaction, that is calcitriol boosts intestinal absorption of both calcium and the phosphorus. So this is the how the activated vitamin D helps in the calcium and phosphorus maintenance. So this is the normal homeostasis feedback loop. First of all, if there is hypocalcemia in the body and it is detected. So hypocalcemia means less amount of calcium in the blood. It triggers the kidney to respond in some way. Kidney responds by release of the PTH or parathyroid hormone. This parathyroid hormone increases in the calcium level and then PTH inhibited. What happens? Raising calcium binds the parathyroid receptor, halting the further PTH release. So when the calcium level is almost in a satisfactory level, then excess calcium ion binds with the parathyroid receptor, which will halt the PTH release. So no more PTH will come. Active vitamin D simultaneously provide direct inhibitory feedback to the glands. So in this way, calcium and phosphate level are restored. Balance is maintained. But what happens when the kidney fail? Number one, phosphate retain. CKD means chronic kidney disease. CKD impairs the phosphate excretion, causing progressive hyperphosphatemia as the kidney loses the filtering capacity. So when the kidney fails to push out the phosphorus, then the phosphate increases inside the body, which will bind with calcium, and the calcium cannot be retained inside the body. Now, calcitriol deficiency. Diminished renal mass blocks 1 alpha hydroxylase activity, eliminating the active vitamin D production and driving the hypocalcemia. So, if the activity of this 1 alpha hydroxylase is blocked, then calcium ion will be decreased in the body. Then what will happen? The condition that is known as the hypocalcemia. Hypo means less. Feedback signal also lost. Without the calcitriol and with persistent low calcium, the parathyroid gland receive no negative feedback. So PTH secretion continues unchecked. So these will happen. These three things will happen when the kidney actually fails. So phosphate will be retained, calcitriol deficiency will be there, and there will be uncontrolled PTH secretion. The parathyroid gland is in overdrive, which is called secondary hyperparathyroidism. What is the compensatory overdrive? Parathyroid glands hypertrophy and means increases in size and hypersecrete PTH in a desperate attempt to normalize the serum calcium. Then when every way is blocked, then parathyroid gland is hypertrophied, means increased in the size. It secretes more amount of parathyroid hormone so that the calcium can be balanced. What is the cost for this? Osteodystrophy. Chronic PTH elevation drives the excessive bone resorption, means releasing the calcium from the bone, which will gradually cause the skeletal integrity, means there will be the bone disease, and this is a very remarkable symptom in case of the CKD patient. Gradually their bones are much more fragile. So what is the clinical impact, or what are the clinical consequences? Number one is metastatic calcification, which is very important. Elevated calcium phosphate product causes the mineral deposit in soft tissue, blood vessel and organ, which is not normal. Next, skeletal fragility. Persistent PTH-driven bone turnover weakens the architecture, increasing the fracture risk and causing the bone pain. So the calcium will come out from the bone. The bone will become fragile and it will be much more fracture prone, and it will cause the bone pain because there is no calcium in the bone, or almost no calcium in the bone. Cardiovascular risk. Vascular calcification accelerates the atherosclerosis, and it is a leading contributor to the cardiovascular mortality in the CKD patient. So, three clinical consequences will be there. Number one, metastatic calcification, in which the uh, calcium phosphate product will deposit in the blood vessel, soft tissue and organ. Skeletal fragility, as the calcium comes out from the bone will be much more soft, fragile and fracture prone. And there will be cardiovascular risk because there will be atherosclerosis, because this calcification will cause atherosclerosis, and which is a very common problem in case of the CKD patients. So what we have to do, or what the body have to do, it will have to restore the balance between all this. So the kidney as a gatekeeper. PTH regulation is just hormonal, not just hormonal. The kidney is the central gatekeeper of the systemic, skeletal and the cardiovascular health. So this is very important. Next, clinical imperative. Early management of phosphate level and vitamin D is essential to preserve the integrity of the kidney-parathyroid axis before irreversible damage occurs. Means if there is deposition, there will be damage, and this damage is irreversible. So always we have to keep in our mind that the early management of phosphate level and vitamin D is very essential. So students, I think you have understood this topic well, and please do like, share and subscribe my channel eduhub.2m, and be with me so that I can upload this educational video more or less every day. Thank you. Thank you very much for your patience listening so long. Goodbye.